All right, let's start. Good evening. Welcome to the November session of Virtual Tumor Board, where we will be discussing thyroid pathologies. My name is Bob Akivi. I'll be your host tonight. Greetings from New York City. It's a crisp fall day here in New York City when the temperature is about 50s and 60s, clear skies for the most part. We are very fortunate to have an excellent panel tonight. Our presenters are Dr. Elizabeth Cottrell, an associate professor of otolaryngology at Thomas Jefferson University, Dr. Jennifer Brooks, assistant professor of otolaryngology from University of Rochester, and Dr. Tanya Fancy, associate professor of otolaryngology at West Virginia University. Our expert panel need no introduction. They are nationally and internationally known faculty and expert in thyroid disease. Dr. Mark Zaffario from MD Anderson, and Professor David Terrace from Augusta University. Welcome, everybody. Let's get started. Our first case is presented by Dr. Elizabeth Cottrell. Elizabeth, take it.
All right, can everybody see my slides?
Yeah.
Awesome. So the first case that we're presenting this evening is the good cancer. So this is a papillary thyroid cancer case. And I'm just going to jump right in if I can get my slides to advance. There we go. So this was a 39-year-old female who presented to us with swollen lymph nodes for about 3 weeks. She denied a history of ionizing radiation. She denied thyroid disorder or a family history of thyroid cancer. She had no tobacco exposure. She did not drink alcohol or do drugs. She denied things like hoarseness, shortness of breath, weight loss, sore throat, palpitations, otalgia, fevers, chills, sweats. And already her PCP had ordered a ultrasound as well as a fine needle aspiration biopsy. So we'll get to those.
Okay. So David, let me ask you, since you see a lot of also neck masses, what's your preference for neck masses? Do you do your FNA right away? Do you send them to get a CT first, ultrasound? How would you like to manage these patients? Most of them are, young, healthy people, and they're freaked out already.
Yeah, to me, it really depends on what the physical exam sort of shows. So if this is a mass that is obviously in the central neck and consistent with a thyroid mass, I might choose one thing versus, say, a bulotable mass in the submental space. I might choose a separate thing. A firm fixed mass in the lateral neck, I might choose another thing. So generally speaking, in my clinic, and it depends where I am, whether I'm in the main clinic or kind of in our satellite clinic, I'm able to actually have on-site cytopathology. So I like to do my own FNA there in clinic and have the cytopathologist come up and read the slides pretty much immediately. That's my preference if I am able to do it, but that's not always an option for me.
Okay. Dr. Terrace, how would you approach this?
My preference is that they already have everything done by the time they get imaging, true. FNA. I try to be like MD Anderson. It's all teed up and ready to go. No, so I completely agree with Elizabeth. It's location. So it depends where it is, and a good history and physical examination will answer much of that. And if it appears to be thyroid, I, of course, would do my own ultrasound. I don't do biopsies myself, but that would be, early on in the process, we get an FNA because that's going to answer a lot of questions.
Okay, very good, Elizabeth.
Wonderful. So the patient on physical examination had a very thin neck, no scars, deformities, or range of motion difficulty. In her thyroid, she had an overall normal size, a palpable 2-centimeter thyroid nodule just to the right of midline. Anteriorly rounded, smooth, moves easily under the strap muscles, but quite firm. Seemed to be pretty much fixed to the laryngeal skeleton, although difficult to tell whether there was any, true fixation there. Lymphatic. So she had a very easy to palpate neck, and in her neck, she had a very easy to palpate 2-centimeter nodule in level 2, firm, rounded, but mobile. As well as in level 4, she had a smaller lymph node, about 1.5 centimeters, also firm and rounded, but mobile as well. And in the left neck, no palpable lymphadenopathy. Nasopharyngolaryngoscopy was normal vocal fold mobility, nothing visible in the subglottis.
Okay. And I see you have some images.
Yeah, so these are a couple of representative images from her outside ultrasound. This was not what I performed in clinic, but rather what she came in with. And so I just kind of grabbed a couple of images to show you guys just a couple of lymph nodes that are rounded, hypoechoic, loss of fatty hilum, various sizes, and you can see in various levels as well. So this is a supraclavicular lymph node. Over here is a level 3 lymph node. And this one was actually just inferior to the inferior pole of the thyroid in level 6.
Mm-hmm.
So you can see a couple of different representative images here. This is an image of the primary mass within the thyroid. You can see here a very classic speckled appearance. I think the microcalcifications associated with papillary thyroid carcinoma are much more sort of appreciable when you're live and looking at a cine loop. I'm sorry that I'm not technically advanced enough to put a loop in my presentation, but they kind of sparkle, and that's sort of the way that that you're able to tell the difference. Between the colloid with the ring or the common tail artifact, and sort of the classic look of microcalcification. So a good representation here. And this is another image showing also these hypoechoic nodules just inferior to the thyroid. The left side,
you're doing the good cancer, you said, right?
I am doing the good cancer. This is an advanced good cancer. I mean, I couldn't be too boring.
Okay, well, we'll get
terms like fixed and firm. I'm like, okay, this is the good one though, right? Okay.
All right.
So left side of the thyroid gland was pristine.
So you got an FNA already, correct?
Yeah, the PCP had gotten an FNA. This was done outside of our hospital, and it was read as atypical cells present. This was in a lymph node, actually. And they called them rare atypical degenerative cells present in the background of a cystic process.
Okay,
so of course
let's just stop for a second. Mark, this patient comes to you, and this is the story. 2 questions for you. I assume that you're going to redo the FNA. If you do an FNA, what would you ask the pathologist to check for? Do you routinely check for BRAF? Do you routinely for other stuff? Do you routinely send all the cancers for genomic testing? How do you approach it? And then I'll ask you the next question.
Yeah, so I think in this case, I mean, the important thing is just to get the diagnosis. We wouldn't be so worried about in a patient like this, 39-year-old, although the patient does look like they have some moderate central and lateral neck disease. I mean, this is not a crazy aggressive, biologically aggressive cancer. I mean, this is moderately advanced disease, and so I don't think we would do genetic molecular testing up front with the information that we have thus far. It wouldn't necessarily be wrong to do a BRAF off of the FNA, but I don't think it's going to necessarily change anything. I think you just want to get the diagnosis, and I think by a repeat FNA, you should be able to do that. Sometimes, I mean, this is a cystic lymph node, so you certainly, this could have been sent for a TG washout too. And if the TG was high in the FNA, that would clinch the diagnosis as well. But if that wasn't done, you could just rebiopsy.
Question number 2: What kind while you're redoing the FNA, do you get more imaging? Because this patient has
I mean, I personally would. For anybody who has lateral neck disease, I would get a CT neck.
CT neck.
And I typically get a CT neck and chest on all of those patients. So, and that's just to both to map the lymph nodes, and because once patients have lateral neck disease, they're a little bit higher risk to have superior mediastinal disease that you may not be able to see so well in the ultrasound, or even rarely retropharyngeal disease. So there's a couple of places like that are a little bit more difficult to see on an ultrasound. And so once you have lateral neck disease, we would want to get CT neck and chest imaging.
David, what would you get for this patient? Would you order more imaging while you're waiting for the good FNA?
Yeah, I completely agree with Mark. So the mention of TG for the lateral neck FNAs is an important mention. As far as imaging, I'm not big on CTs, but I agree with Mark. Once they have lateral neck disease and they're going to get a neck dissection, we want to make sure we don't leave disease behind. And he mentioned the 2 areas of most interest, so retropharyngeal and superior mediastinal. So as I get my head and neck colleagues involved to do the lateral neck dissection, since I no longer really like to do those anymore, that's what they're going to want, just to make sure that they don't leave disease behind.
And you get it with contrast, and you don't care that somebody gonna raise hell saying, "Oh my God, you get contrast, I can't do that." REI.
So I'm going to credit Greg Randolph publicly for kind of
He's
moving
here.
the field in that direction to say, look, a good surgery is better than prompt radioactive iodine, is the way Greg used to say it. And I think most endocrinologists are comfortable with that. If it's somebody you don't work with a lot, it's worth mentioning to them what you're planning to do. But I certainly would say CT is appropriate.
Perfect. Yeah. Well, and Greg's here. And the credit is due. Okay, Elizabeth, tell us what you decide.
All right, so I agree with our discussants. So we plan to repeat FNA as well as a CT scan of the neck and chest. So repeat FNA showed in the right thyroid positive for malignancy. Papillary thyroid carcinoma was consistent with that. We did not get an IHC on this one. We usually will get a BRAF IHC. This was actually done at one of our outside sort of satellite centers, and they didn't do a BRAF IHC, but that is pretty common at my institution. In the lymph node, also positive for malignancy, consistent with papillary. These are a couple of sort of representative sections from the CT of the neck. I did not include the CT chest because it was completely pristine.
Okay. So seems like you have good amount of disease on the right neck. And did you see any evidence of tracheal invasion, any local invasion?
No. So you can see on this kind of bottom left image here, there's actually a nice sort of rim of pretty much normal thyroid tissue abutting the trachea. Nothing really in terms of intraluminal extension here. Same thing with the esophagus, pretty normal there. There were a couple of pretty large lymph nodes in the central neck that were obvious on the CT. This was one of the largest one, about 1 centimeter or so, and just inferior to the inferior tip of the thyroid.
So Mark, I assume that you look at your CTs yourself. What is it for a neck CT that for these kind of patients that you look for? What are the areas that you pay extra attention?
Well, I think in terms of the thyroid disease first, you want to see if there's any extrathyroidal extension, and anterior extrathyroidal extension is not as worrisome. I mean, if it's involving the straps, obviously you can resect the straps easily as a margin. But if there's posterior extension into the groove, where it would be abutting the trachea, esophagus, and/or nerve, that's important to know. Also for counseling the patient up front, does not look to be the case here. And then, in terms of nodal disease, as we talked about before, you're looking at the superior mediastinum, you're looking at the lateral neck, of course, and mapping those lymph nodes, and then sort of commonly missed lymph node, locations, carotid vertebral nodes, sort of medial nodes that track along the superior thyroid artery that are sort of borderline central lateral neck lymph nodes, more posterior lymph nodes in level that sort of border level 5, at the posterior border of the SCM, and also, low level 4 lymph nodes where you're going to be have the thoracic duct branches at risk. So those are some of the places where you're sort of looking, and here you see that the patient's got a paratracheal lymph node that's in the tracheoesophageal groove here, and so that's probably going to be okay in terms of the nerve. Does not look like it's involving the esophagus or the trachea, but certainly you'll be meticulous in that area.
Right. So David, you got the scan, you have the biopsy. You don't want to do surgery. I mean, this is what are you doing? BRAF, targeted therapy, immunotherapy, radiation.
Yeah, right. So just to mention about the BRAF. So that's not something we focus on very much. I'm not sure it's a helpful distinguishing marker so much, because so many of papillary cancers are BRAF positive. But I literally today had the father of a young woman I was doing a lobectomy for a small cancer on, and he requested that we get BRAF on the pathology. And I was a little bit surprised. I said, okay, we can do that. Can I ask why? Oh, I don't know. I just read that you should do it. And so I don't know what I'm going to do with that information. Elizabeth, what do? You said you get IHC for a lot of these patients. What do you do with that information? And I can completely understand if it's for academic reasons and answering questions and writing papers and so forth. But for a specific patient, does it affect how you manage them?
I don't think it really does, affect our management necessarily. I think it may if we get it on, say, an FNA and it's positive, we may be a little bit more, I shouldn't say I may be a little bit more sort of suspicious about lymph nodes, things like that, depending upon the size, obviously, of the lesion. But, but even then, it doesn't necessarily change management. I would still, do the same workup, same management for the patient.
Okay. All right.
But
So
I can answer about my surgical management.
yeah.
And I hate for this to be the quote Greg Randolph show, but nodal mapping, very important. And that's why BRAF matters less to me. I'm looking for where is the disease that's imageable, palpable, and that's what we're going to go after with the surgery. And in this case, it's going to be a central neck dissection, total thyroidectomy, right lateral neck dissection. And as I said, I work with partners on this.
Sure.
So I do the central neck stuff. They do the lateral neck stuff.
And then let me ask you this. We always have these kind of nitty-gritty of it. Do you do a full central compartment on both sides or just limited to the right side?
Driven by the imaging, and my preference for the patient is to do unilateral. And on that side, virtually always, I'll reimplant the inferior parathyroid gland, mostly because you can anticipate, nodes beget nodes. And so you can anticipate, and this is something I would share with the patient. This patient is going to take a little while in terms of counseling. First, tucking her off the ledge because many of them are anxious and they have metastatic disease. I make sure they hear stage 1, your stage 1 disease. And so secondly, I tell them you're likely to have a recurrence. It's okay if you do, we'll manage that. But it's nice if you can have a parathyroid stuck in an SCM someplace out of harm's way.
Sure. Mark, do you do bilateral central compartment or unilateral? How do you manage the central compartment?
I would base it off imaging and intraoperative findings. I mean, I think many times I would probably do sort of at least, obviously in this case, you're going to do a right central compartment dissection, but on the left, I would probably, as I'm dissecting the nerve down, I'd probably pull everything medial to the nerve and include that along with all the sort of midline pretracheal and right central compartment together. So I would probably do some degree of limited central compartment dissection on the left as well in a patient like this. And if there's grossly metastatic lymph nodes there in the midline and or sort of cheating toward the left side, then I'd be a little bit more formal about it.
Perfect. All right, Elizabeth, got 2 more minutes. Let's go.
All right.
Tell us what you decided.
So took her for a total thyroidectomy, right modified radical neck dissection, and a central neck dissection. We did a pretracheal, prelaryngeal, and a right neck dissection. Really wasn't much of anything in that left central neck. Definitely did evaluate the lymph nodes there, but not really much that was on the left side. Pretty laterally based nodule as well. So not that surprising that there wasn't much there. She was definitely found to have a large conglomerate of nodules in the central neck that were basically surrounding her recurrent laryngeal nerve. Thankfully able to kind of pick these off and knife these off of the nerve and save the nerve entirely intact. It was stimulating, obviously had normal function ahead of time, so it was stimulating well after picking those lymph nodes off the nerve, which was very, very much a breath of fresh air. I think I spent a lot of time doing that, but that's what we do for our patients, right? Definitely had some bulky firm lymphadenopathy also within levels 2, 3, and 4. Not really much of anything in level 5. There was kind of a smaller one up in level 5. No obvious extra nodal extension in those lateral neck nodes, but definitely in those central neck nodes. So she had normal calcium postoperatively. JP was minimal. She was discharged on postoperative day 1. I saw her postoperative day 8. She was healing great. She had normal vocal fold mobility on her NPL, thankfully. Her calcium was 10.0. She wasn't taking any calcium supplements, which was great. She was put on Cytomel, kind of expecting possible radioactive iodine. And her final histopathology was a 2.1 centimeter classic type papillary with no extrathyroidal extension, was BRAF positive and did have positive LVI. Lymph nodes in the right level 6 and the central pretracheal prelaryngeal lymph nodes. She had 11 of 16 positive with definitely positive extranodal extension. The largest met in this area was 1.6 centimeters. In levels 2 through 5, she had 5 of 24 lymph nodes positive for metastatic disease. The largest was 2.5 centimeters and no extranodal extension. She did receive I-131.
Before you go forward, one question, quick question for Mark. I was at Memorial the other day, and Fagan was saying that if BRAF is positive, radioactive iodine doesn't work anymore. And also, the question is, if this patient comes in before REI and her thyroglobulin is 0 or undetectable, would you guys still recommend REI, or now the pendulum is swung?
I think the pendulum is definitely swinging toward less RAI and lower doses of RAI. So I think that much is clear. I think this patient with this degree of 16 out of 40 metastatic lymph nodes would still get an RAI scan at least at our our center, where it is true that BRAF mutated tumors are a little bit less radioactive iodine sensitive, but that's just a general trend. That is not uniformly the case. So this patient would probably get a radioactive iodine scan, and if they had uptake on the scan, then they would get a dose of radioactive iodine. I mean, these are typically small doses of radioactive iodine. These days more in the 30 to 50 millicurie range, rather than what used to be seen as like 100 or 150 millicuries. So I think she would get a scan and maybe a low dose RAI.
David, what do you think? I think these panels aren't as interesting when the discussants always agree, but I agree with Mark in managing it. Just a quick word about the sequencing, because you mentioned the surgery. And by the way, getting a temporary dysfunction, especially when you've done the other normal lobe, and then you go back maybe and do the central neck dissection, it's no problem. I think that's a good time to be aggressive and get that nodal disease out, especially deep to the nerve, because you don't want a recurrence there. So I sequence it. I do the right lobe, then I do the left lobe, then I go back and do the right neck dissection, because that way at least I've taken out the entire thyroid. If I lose signal on the left, I'm probably going to be done. But if I can maintain signal on the left, I go back to the right and I aggressively remove those nodes. And again, if I lose signal, that's okay. It'll recover. She's young. She's not going to aspirate and so forth.
Great.
If I can ask a follow-up question of the panel. So if you lost signal on the right side with the left lobe still remaining to be done, how many would stop the surgery? I mean, you're going to talk to the family. How many would you stop the surgery for a delayed completion, and how many would talk to the family and move forward with the completion, knowing that you only have a single functioning nerve on the contralateral side?
Okay. Mark, what would you do? You stepped out of the room and you come back and the fellow, something happened, and now it's not you. Just the nerve is not
sure. Well, I think with the neuropraxia, as Dave just mentioned, most of these are going to recover, but the safest thing to do would be a delayed completion. I mean, I think that should be the textbook answer here. I mean, depending on the circumstances of the case, I mean, that may or may not always be what I would decide to do, but I think that would be the textbook answer, is if you lose signal on the right and it's a neuropraxia, even if it's not a neuropraxia. I mean, if you severed the nerve on the right side, you could make an argument that just to leave the left side, since there's no known disease over there, and not give radioactive iodine. But certainly if you have a neuropraxia, those are 99% of those are going to recover, and depending on the injury, and you could bring the patient back for a completion and later, and it wouldn't really hurt anything at all.
Right.
All right, we found something to disagree on.
No, those are great points. Great point. And thank you. And I see Dr. Brandon Stack also and Dr. Volpe say that they would delay the completion. I think that's the safest thing. Basically, do whatever you're comfortable, and there's no shame in coming back. It sounds like
Dave has a disagreement here, though.
I do have a disagreement. I think if the nerve is cut, I would have a low threshold for going to the other side and taking care of that lobe, not with the resident, with me doing the case. If it's a temporary, there is a cost associated with an emotional and financial and risk cost associated with staging the operation. You're always okay to stage it, but I think you're okay to go to the other side as long as you've had that conversation with the patient before surgery.
So if you go to the other side and one nerve is already cut, and God forbid anything happened to that other side, then you're looking at a tracheostomy.
Potentially, not necessarily a
Potentially.
tracheostomy.
Yeah.
But there's lots of risks to surgery. And so
Sure.
again, there's risks to staging it. I just want to make sure everybody hears that. There's risks to staging it as well.
All right. Well, this was the easy case. So we have two more difficult. Elizabeth, any last thought?
Just she's doing well.
Okay, great. Then TG is was the TG undetectable before RAI? Do you know?
That's a good question, and I actually don't know that. I also don't know the dose of RAI that she received. So sorry about that.
Okay. No worries, no worries. Because we used to say if the stimulated TG is negative before the RAI, they probably can skip the RAI. But anyway, all right, let's move on with Dr. Brooks's case. Thank you so much. That was an excellent case. Jennifer, are you ready? Can you start? Sorry, we went over a little bit.
All right.
Thyroid is always interesting.
That's good. All right. So I'll be presenting I think this is the bad cancer. Thanks for the chance to present this case on medullary thyroid cancer. Let's see here. So this patient was referred, a 48-year-old female, she was referred for evaluation of right thyroid nodules that were actually found initially incidentally on a CTA that was done after a stroke. She had not a healthy lady, past medical history of stroke, likely due to uncontrolled diabetes, diabetic eye disease, hypertension, multiple ophthalmologic surgeries, no neck or cervical spine surgery. She had no family history of thyroid cancer, no other noted endocrine disorders in any family members, and she had no radiation exposure. On exam, she did have a palpable right nodule on the right lobe of the thyroid. This was foramen elevate with swallow, and she was sort of a larger lady, so her neck was a little bit difficult to palpate, but thought there was something in the right level 3-4 as well. Her laryngoscopy was normal preoperatively. She had a thyroid ultrasound that showed right-sided suspicious nodules that were solid and hypoechoic with some punctate foci, and then some prominent and suspicious right level 4 and 6 lymph nodes. Her left lobe was notably negative. And then the CT neck corroborated these findings as well.
So you have unilateral neck disease both on CT and you have lateral neck disease, correct?
Correct.
Okay.
Yes.
Okay.
So
Quick question for Mark. Mark, do you routinely get CT for all your imaginaries?
Yes, yeah, we get a high definition ultrasound and a CT neck and chest for those patients.
Great, thanks. All right, continue, Jen.
Great. So some representative images here from our ultrasound, and then I have the CT next showing right-sided about 2.2 centimeter hypoechoic lesion. There's a smaller one as well, and those were both suspicious. And then CT here showed that, again, the dominant nodule on the right thyroid lobe and some suspicious level 4 and level 6 paratracheal nodes on coronal and axial imaging here.
Okay.
So she underwent FNA of the suspicious right thyroid nodules as well as right level 4 nodes. And the right smaller nodule actually was confirmatory for medullary thyroid cancer, as was the lymph node.
Okay.
This is actually a nice image that our pathologist donated to me of a red Congo stain showing this characteristic apple green birefringence associated with medullary cancer, and allowed us to have this diagnosis.
Perfect. All right. And so before, we know the management for the most part, but before you take the medullary patient to the OR, Dr. Terrace, what are the tests that you would like to have before you put the patient under anesthesia? What's your routine?
Yeah, the main thing is to rule out syndromic disease, because you don't want somebody to have an adrenal and take a bad problem that she has now and make it worse by putting them under anesthesia and having a catastrophic event. And so careful history, calcitonin CEA to see where you stand, just how bad is the disease. You can see it's not so friendly on the CT imaging, but those numbers will tell the story. And then depending on the timing and the circumstances, you'll need to be RET tested and rule out an adrenal tumor either by CT or catecholamines or RET testing. So those are the main things that I'm going to want prior to surgery.
Do you get CEA and calcitonin pre-op on everybody?
On all medullaries, yes. If you're asking like on all thyroid nodules, no.
No.
We don't in this country, but overseas, that's a common approach, as you probably know. But no, if it's a medullary, for sure, calcitonin CEA.
Calcitonin and CEA, and you would prefer to have a red proto-oncogene on everybody before you take them to the OR?
Not necessarily before surgery, depending on the age. But it's helpful. But mostly, I just want to know they don't have an adrenal tumor. The red proto that can take several weeks to come back. So
Mark, do you get red proto-oncogene on everybody before OR?
I agree with Dave. I mean, we do order, the hereditary RET testing immediately, which in this case, your suspicion's a little bit higher because it's multifocal disease, which is more common in hereditary disease. But you don't necessarily have to wait for that to return to take the patient to the OR as long as you rule out an adrenal tumor.
Perfect. Great point. Thank you. Okay, Elizabeth. Oh, sorry, Jen.
All right. So thankfully, I can get this to go. Thankfully, we did do most of that workup. So she had her, obviously, thyroid function check was normal. No hyperparathyroidism noted. Her calcitonin was markedly elevated, as was CEA. And she did notably have normal plasma metanephrine and norametanephrines to help rule out pheochromocytoma.
Okay, go ahead. Additional imaging.
Okay. So she additionally had a CT chest that was negative and a CT abdomen specifically to look at her liver and adrenals, which were normal. She had an MRI brain, I think, after her stroke. So I included that, but that wasn't, I don't think, part of her actual staging workup here. And then we kind of already addressed this question of RET germline testing, which she did not actually have preoperatively and has it pending still now. But that was an important point of discussion too.
So Mark, this patient had a calcitonin of more than 5,000. What does that mean to you when you see these?
That means that the patient is very likely to have distant disease. I mean, typically, if you look at large studies of these patients, if you have a calcitonin over around 500 or especially 1,000, your risk of distant disease is very high, and also at that level of CEA. It's not uniform. I mean, I think we've all seen rare patients that may have a calcitonin of 3,000 and they can still be biochemically cured with surgery, but that's not the norm. Usually, if their calcitonins in the thousands like this, they're even though the imaging is negative, and we probably also get an MRI of the spine as well. But assuming she's structurally negative, she's still unlikely to get a biochemical cure here.
Would it change your operative plan?
Yeah, so there's controversy in the literature whether you sort of need to do this whole distant workup before surgery or not, and you really don't need to. It doesn't. In a case like this, everything. Although the patient does have nodal metastases, I don't think we've actually seen the CT imaging yet. So I think I would want to see the CT imaging and kind of see, because there was some question of some extension into the TE groove. Actually, we saw the CT imaging a while ago, but I want to look at that TE groove and sort of look at that a little bit more closely. But there we can. There it is right there. So there is some sort of bulky nodal disease that's in the TE groove. These patients, this is certainly not standard of care at this point, but if this patient does have either a germline or a somatic RET mutation. So even if they're germline negative, you can still test the tumor based on a FNA cell block for RET, and even 50 to 60% of those who are germline negative will still have a somatic RET mutation. So the chances of this patient having a RET mutation is at least 50 to 60%. And there are novel drugs that you can give the patient we're studying this in clinical trials in a neoadjuvant setting. Typically, these patients have about a 50 to 60% resist response to drugs. So if you have a more local regionally advanced tumor where you're concerned, about potentially, the tracheoesophageal groove or something like that, that is an option. Again, we're looking at that in the setting of clinical trials.
Sure. Great point. Thank you. Dave?
Yeah, I mean, not much to add. Similar in terms of workup, and I guess we're going to get to the surgery. So, but yeah, I agree with all that Mark had to say.
Okay. All right. Jen, what did you decide?
So yeah, we did discuss her at our tumor board prior to surgery, and those exact discussions came up in terms of whether to do the ipsilateral or obviously the ipsilateral, but also include the contralateral lateral neck, and discussion and per guidelines with a calcitonin that high that there's high likelihood of bilateral and distant disease. And so we opted for sort of maximal surgery. She underwent a total thyroidectomy, bilateral central neck, right level 2 through 5, and a left 2 through 4 neck dissection. Her pathology, and then I didn't include all the details intraoperatively, but her everything was pretty straightforward. The thyroid peeled off pretty well. The central neck nodes, those paratracheal nodes, were sitting closely associated with the nerve, but felt that it was able to be dissected away cleanly and maintain good signal. So we were able to get the whole thing out, and she did well postoperatively. Her path,
yeah, it was
okay.
showed multifocal medullary thyroid cancer, and the tumor didn't have any extrathyroidal extension. Central neck did have a significant number of positive nodes with extranodal extension, as did the right neck. And thankfully, the left lobe, left central neck, and left lateral neck were all negative for disease.
Great.
Just
So
one comment
go ahead,
there.
Mark. Yeah.
Babak and Jen. So there is controversy in terms of the, whether or not to electively dissect that left lateral neck. I think, there's controversy in the guidelines. If in fact, the ATA guidelines sort of suggest that, that you can either go by imaging, which, in this case, the ultrasound and CT imaging were negative, or you can, some people use calcitonin as a guide. And if you've got a calcitonin of over 200 is sort of commonly used cutoff, some people will consider an elective lateral neck dissection. We've actually, elective contralateral.
Oh, really?
Yeah, contralateral actually. And that's what was done here, is an elective contralateral.
Yes.
So we actually studied that issue. We did not see a difference in biochemical cure or outcomes when you did elective versus not in those types of situations.
Correct.
But so our practice is we don't do elective lateral neck dissections, even in the case of medullary, but there is differences in practice in that regard.
Exactly. That's what I was going to ask. David, so you have good imaging. The right side is obviously disease. The left side on your CT is negative. But you do have a calcitonin of 5,000. Would you do elective contralateral lateral neck?
I wouldn't be critical of somebody that did, but I'm with Mark again. And I was glad that the MD Anderson group published their data that suggested exactly that. It doesn't really help you by and large. So this is a case you want to be aggressive, and especially the central neck. Unlike the previous, papillary, this is a case where you can, even though her calcitonin is 5,000, you want to clear that disease aggressively, in my opinion. As long as her nerves are working properly, I'd be aggressive in the central neck and the right lateral neck. I'd probably leave the left neck alone. Maybe the only good thing is she's 48 with retinopathy in bed, had a stroke. She may actually die of something other than her medullary thyroid cancer, because she seems so unwell. But this is, again, back to counseling. This, careful conversation with the patient about what to expect. And as Mark said, probably not curable. They need to hear that up front, but it's treatable, and we're gonna do everything we can and so forth. But you kind of need to set the stage for what's likely to be coming down the pike.
Great. So I gotta move on to the next thing. But Dr. Stack, I see Dr. McCammon and Dr. Randolph, if anybody would at any point saying, different commentary, because we have David and Mark who agree with each other 90% of the time, and kind of like making my work difficult a little bit to stir some controversy. But anyway, great case and great. And as Dave said, Jen, I don't think anybody can criticize you done safely. You basically address the entire neck in one session, especially for this patient that doesn't have zero risk for multiple anesthesia. Right. The outcome would change or not, that's a great question. I think Mark's point is very well taken, but at the same time, I think you did what you thought that's the most the safest and the most expedient. Okay, did you have a post-op calcitron?
I have, no, unfortunately. So I had her path that showed nice amyloid slide, and then yeah, unfortunately, this was relatively recent. So she's actually seeing endocrinology tomorrow. So I sadly don't have the end of the story. But in discussing her already with endocrine, I think we will not be surprised, like was mentioned, if she's not biochemically cured with the calcitonin that high. And, she didn't have any evidence of distant mets so far on the imaging, but she'll get likely more sort of comprehensive staging workup now.
Jen, can you send an email with a post-operative calcitonin? We're all very curious.
I'd be happy to.
Okay, thank you.
Great. Okay, fantastic. And unfortunately, we don't have time right now to go to long-term management, but that is mostly directed by levels and anatomic imaging, so on and so forth. And I don't think any of us will start her on anything right now. All right, fantastic cases. Okay, Tanya, you're up.
As we make that transition, I just want to point out, I put a link in the chat. It's a very large paper, I think it's from Germany, which is Dry's experience with a couple hundred medullary thyroid cancers and looking at calcitonin level and extent of disease. It's a useful piece of data when you're trying to figure out, where the calcitonin level lies and the likely extent of disease.
Yes, just going to editorialize. If you know Henning Drala, terrific, amazing surgeon, there's a little bit of dogmatism in his work, and so
German and dogma.
Mark's more recent data too. So I'm sorry.
I said Germany and dogma. What are you talking about? All right, it's called discipline. Let's put it that way. Okay, Tanya. Actually, I've looked at that German reference quite a bit. It's a very well written paper. It's very, very useful. I agree with Tanya. I see Tanya here. You're still muted, and if you would like to start sharing.
Sorry about that, internet issues. I'll share right now.
Oh, okay, no worries.
Okay, so this is case number 3. This is apparently the ugly. Okay, so a 56-year-old lady who presented with a 1-year history of known goiter or thyroid enlargement, who now presented with a 2-week history of dysphonia with difficulty and painful swallowing, currently unable to swallow solids, and she also endorsed some left ear pain and some fullness in the left neck. Family history, colon and breast, no family history of thyroid cancer. She does endorse a significant history of cigarette smoking. The referring physician that she has sort of the quote-unquote aggressive kind of thyroid cancer. They did perform a needle biopsy at the outside facility, and then she was sort of transferred to us.
You're kind of going in and out a little bit. So 56 is kind of young for
a fairly large tender lymphadenopathy on the left side that seemed to extend all the way to under the mandible.
Oh, wow.
Flexible laryngoscopy, the true vocal folds were mobile, but they seem to be a little bit of asymmetry, possibly a little bit slow on the left side. She had an ultrasound report that she brought with her that showed a solid mass with some calcification on the right thyroid, and then 3 separate solid masses within the left thyroid lobe that were each somewhere between 2 and 2.5 centimeters. CT chest was done, and this was actually ordered by us. She had no evidence of distant metastatic disease. She did have a CT neck also that we obtained, and that showed, as shown on the ultrasound, bilateral thyroid masses, the large one on the right that was calcified, and then 3 separate masses within the left. And then also a conglomerate of lymph nodes on the left neck that appeared to at least compress or efface the IJ on that left side. And it did actually appear to be circumferential around the carotid artery.
Do you have
So-
any? Okay, there you go. Okay.
So you can kind of see the top 2, of course, are coronal images. You can see on the one that's on the screen left, large calcified thyroid mass on the right and a part of one of the masses that are on the left side. But then you can also see where it sort of just merges with this bulky lymphadenopathy that you're seeing in the left neck. And you can sort of see the contrast come in and then go out again on that carotid and on the jugular. The lower just shows that those thyroid masses essentially do look that they're confined to the thyroid, but they're those enlarged lymph nodes under the SCM. Does not appear to
Tanya,
have obvious.
do you have an FNA?
I do. Sorry, next slide. So FNA was reviewed at our facility. They called it positive for malignancy, but they said it could potentially represent anaplastic versus metastatic disease from a different source. And then they raised the potential that this could also be medullary carcinoma. So they didn't have enough tissue left to run additional testing. So we had her get a repeat image guided biopsy, and it did confirm undifferentiated or anaplastic carcinoma.
Okay.
She also, of course, had an MRI brain to rule out intracranial disease, and that was negative.
Good. Well, let's stop here for a second. David, a 56-year-old man, comes in. The thyroid, it looks, bad. It was not terrible. The neck looks super ugly, and now you have a good biopsy that shows anaplastic or polyp. First of all, he's quite young for anaplastic, but how would you approach this? What your thought process?
Once again, I'm always looking for the good news. And the good news is Augusta has direct flights to Texas. I don't think to Houston, but at least you can get to Dallas. And then from there, you can drive up to Houston. Yeah, this is going to be, a bad case. The things I would toss out. So if the first biopsy comes back negative, we did a second FNA. This is a case where you might even consider a core needle biopsy just to make sure you get the diagnosis. A calcitonin level staining of the specimen, but also a serum level can probably rule out medullary. But now we have the diagnosis, and it's bad disease. When it's circumferential around the carotid artery, it becomes non-surgical disease. Most of anaplastic is non-surgical. I've got 2 long-term patients, one that went for about 2 years. So if they have confined disease, I'll operate on them. But generally it's a non-surgical disease, and so in this lady, she doesn't need surgery.
The fact that the brain is negative, the chest is negative, does that kind of increase your enthusiasm a little bit? No. Okay.
See many of these.
Mark, tell us, what would you do for this case, and what kind of test you get when the biopsy comes at poorly differentiated or anaplastic?
Yeah, so you'd want to immediately do BRAF testing by immunohistochemistry you can either do it from a FNA cell block or a core needle biopsy, as Dr. Terrace mentioned. So you'd want to definitely do that BRAF immunohistochemistry on the FNA cell block or core. And that typically takes 2 or 3 days to come back. And if there is a BRAF mutation, then you'd want to immediately start the patient on BRAF MEK inhibitor. It's the BRAF MEK inhibitor combination that's FDA approved for anaplastic thyroid cancer is dabrafenib trametinib. And that's based on a very good evidence in the literature that led to that FDA approval several years ago. So those patients can often have rapid and dramatic responses to BRAF MEK inhibitor. So that's about a 40% chance that the patient would have a BRAF mutation. If there's not a BRAF mutation, certainly simultaneously, you could send a full genetic panel, next generation sequencing, including fusions. There are some rare fusions, such as NTRK or even RET fusions you can see in anaplastic thyroid cancers. Those are typically like 1%. And so they're not very common, but those are also targetable, with NTRK inhibitors, which are FDA approved as an agnostic indication for any patient with an NTRK fusion or RET fusion. There's FDA approved drugs for RET fused thyroid cancer. So those would be other options. But other than that, you're going to be probably looking at either if it's not BRAF mutated, you're going to be looking at either assuming that carotid is really 360 encased, and this is an anaplastic thyroid cancer. I agree with Dr. Terrace. You're not going to be really considering surgery, so you're going to be looking at chemo XRT for that patient if they do not have a BRAF mutation, or you could consider some other type of drug therapy combination, like lenvatinib, Pembro, or something like that.
Great. So again, the great points. And in 2021, so in 2022, really anaplastic deserves that genetic testing. All right. What did you decide, Tanya?
So her calcitonin stain was negative, and here we go. So we presented her at Tumor board, and of course the consensus was surgical management is not recommended at this point. She chose to have treatment close to home, so we referred her to radiation oncology and medical oncology close to home. They started aggressive chemoradiation therapy with weekly adriamycin and radiation. They had planned 60 gray, but due to some side effects, she didn't complete the entire course of the treatment, but made it through most of it. Biggest issues for her were mucositis and xerostomia. She presented back a couple of weeks after radiation therapy with repeat scans as a referral from the medical oncologist to consult regarding surgical options. Because when you look at these here, based on the report, improvement in adenopathy in the left neck, that sort of conglomerate group of lymph nodes that previously was about 5.5 centimeters had decreased significantly. We're now looking at 2.5 centimeters. Of course, both sides thyroid nodules were stable and unchanged. IJ still seemed occluded. When the radiologist reviewed the CAT scan, they seemed to think, although the lymph nodes are surrounding the carotid, they're much smaller, and it did not seem to be, did not appear to have any actual invasion of the carotid artery.
Okay.
So then her question is where to go next.
Well, now you have a radiated neck. Mark?
Well, I think you'd want to go back to the genetic molecular testing. That would drive everything in a case like this. So you'd want to know what's the BRAF status, any other fusions or mutations. So that would be the first thing, and very important. And then I think that drives everything else. I think it's this patient's been radiated now. I mean, even if the disease is not completely encasing the carotid, it's that's going to be a very, very difficult surgery in a radiated neck. Any thyroid surgery in a radiated neck, and then add to that you've got disease that's on the carotid and been radiated. I don't think that this surgery is going to be your first choice here. So I think you're still going to be looking at potential systemic therapy options, most likely.
Okay.
So her BRAF was negative, no RET either, unfortunately. She did go ahead and have surgery. She had a total thyroidectomy with both necks done, as well as central neck dissection. Her IJ, of course, was involved, and that was sacrificed. Both recurrent laryngeal nerves were preserved. By the time she came back to us after her radiation, her left vocal cord that was previously weak was completely out. However, intraoperatively, it was preserved. It didn't stimulate, but the right side did. The carotid artery, the lymph nodes actually peeled off fairly nicely, so it wasn't an issue. The carotid did not have to be sacrificed. The final pathology you can kind of see here, they actually found Hürthle cell carcinoma, and the component of anaplastic that they found after her treatment was less than 5% of spindle cell type of anaplastic. She had 4 of 34 lymph nodes, which when they assessed, they called it non-viable tumor. They were all on the left side, which was ipsilateral to her Hürthle cell. The right side, incidentally, that large calcified nodule ended up being not malignant. And her BRAF, even on this, was negative. She had a RAS mutation, and they tested this sample as well. Calcitonin and TTF1 were negative.
So question for you, Tanya, do you think that the original diagnosis of anaplastic was correct?
You know, it's hard to say when you look at all this in retrospect. Just the way it presented definitely was worrisome for anaplastic.
Mhm.
And
Absolutely.
when we reviewed it at our tumor board, I have to say, full disclosure, this she actually presented to one of my partners. I'm running out of anaplastic cases to present. But yes, that was the tumor board consensus. That's why we went for the additional biopsy with the larger needle to try to confirm that it was anaplastic. They were fairly confident. So just now in
Yeah.
retrospect, looking at this pathology, you kind of wonder, could it all have been just Hürthle cell with, it's not uncommon to have nodal disease with Hürthle cell
Yeah.
and still be a much more curable disease. And it would make more sense to be more aggressive with those patients than it would for anaplastic.
Well, fantastic case. Mark, question for you. How often have you seen this good response with just radiation and adriamycin?
I mean, I think this is a good response. I don't think it's remarkably good. I mean, in terms of, I think you see this in some patients. I commend you on the surgery. I mean, obviously, I think if you're thinking that you would have to do any kind of a carotid resection in a case like that, I mean, in the setting of anaplastic thyroid cancer, it's not typically something you would do. But obviously, you guys must have seen on the imaging that you thought that had a good chance of coming off the carotid there. So sounds like a successful surgery. I think obviously she's going to be this patient's going to be at high risk for other disease, whether distantly or local regional and recurrent disease, but certainly a good sort of intermediate term result here.
Yeah. And looks like Tanya has some more. So what happened to this patient, Tanya?
So unfortunately, she had about a 4-month technically disease-free survival, and then she presented with abdominal pain and a mass within the the abdominal wall. Imaging showed that she did have what appeared to be metastatic disease to the right abdomen, and then also bilateral adrenal glands eventually. They started her initially on maintenance immunotherapy. They tried a MEK inhibitor, but due to side effects, that didn't quite work. So she continued with Abraxane and atezolizumab, always a tongue twister, sorry. She had a couple of courses of radiation therapy for true palliation, and then eventually she succumbed in October of 2019, which if you look at the time frame, that was about 2 years from her original surgery.
And she didn't die of suffocating in the
Correct.
neck, which is not for nothing. Obviously, it's a very challenging case. David, any comments?
Just a couple quick comments. By the way, if I knew it was Hürthle cell, I probably still wouldn't have operated. But fantastic, you guys were able to get some disease-free interval there. Although I wonder if the surgeons looked back at this case and thought they did her a good turn or not. I don't know. But it reminds me. I thought we were going to be talking mostly about anaplastic, and I was thinking about my first speaker at our thyroid course in Augusta in 2005 was Helmuth Gepfert. And he made a comment, and my eyes went this big because we were talking about anaplastic, and everybody said, well, with trach and blah, blah. He said, no, I don't trach those people. I never trach anaplastics. And it blew my mind. But, you have to balance the treatment and the longevity, and are you helping the patient out? One of my most grateful families on whom I operated for anaplastic succumbed, but died without a trach. I resected his disease, a young man, like in his 30s, and was able to spend his remaining months with his kids without a big tube in his neck. And so it's his family. I still get cards from them. Very grateful for having that opportunity. And so maybe Helmuth was right.
Yeah, and the point is really anaplastic is an ongoing area of research, and in this day and age, we will benefit our patients if we go out of our own institution and reach out to others and discuss them. And as Tanya clearly showed, be open-minded, not having one dogma that's saying operate, no operate, trach, no trach. What we just have to tailor it to the patient. And these new genetic mutation panels are coming and getting better and better. Targeted treatments are getting better. We all can go back and look at patients who had amazing responses. I think Tanya, you presented a case a few months ago that also had a very good response, that patient. And don't underestimate the benefit that people get from surgery, even if it's fake surgery. This patient survived 2 years. All right, great. So Mark, you have two trials for these, correct? And MD Anderson one trial for anaplastic, which is neoadjuvant.
Yeah, we have a neoadjuvant dabrafenib, trametinib, pembrolizumab trial for BRAF mutated patients, and for ATC, and then we have a neoadjuvant trial of selpercatinib for RET mutated local regionally advanced MTC.
Now, let's say if
those are
someone,
the two neoadjuvant trials we have right now.
if someone comes up with an NTRK inhibitor and let's say locally advanced disease, would you consider doing NTRK and then add neoadjuvant and then operate?
Absolutely.
Yeah.
Yeah, we don't have a trial for that. But absolutely, for an NTRK fusion, we would consider larotrectinib or one of the NTRK inhibitors followed by surgery.
Perfect. All right. Well, at the end, we have reached the end of the hour. Just flew by. Thank you so much. This was a fantastic session. I cannot thank you all for being here and participating. Special thanks to our case presenters, Dr. Cottrell, Dr. Brooks, and Tanya, Dr. Fancy, and also our experts, Dr. David Terrace and Dr. Max Deferio, and all the audience. Dr. Stack, I saw that you was commenting throughout the cases. Thank you so much, and all the other folks that were present. Our next session is going to be the first week of December 1st, actually, on advanced skin cancer. That's going to be our last session for the year. I hope I see you all there. And last word, have a very happy Thanksgiving. Stay safe with your families, and even in the middle of pandemic, if you have a lot to be thankful for. So great having you all. Have a great night from New York City. Farewell.
Great cases, ladies.
Thank you.
Thank you.